Hello and welcome to the GRACE video presentation on the distinct features of the lung cancer seen among never smokers. My name is Dr. Jack West and I'm a medical oncologist and the medical director of the Thoracic Oncology Program at Swedish Cancer Institute in Seattle, Washington. I also serve as the president and CEO of GRACE, the global resource for advancing cancer education. A transcript as well as a PDF file with copies of figures associated with this program are available at www.cancergrace.org/GRACEcasts. This video presentation is in loving memory of Juan Mike Chen, who fought not only for himself, but participated in research to help others fighting this disease. The information provided here includes my own views, and they are not necessarily those of the Global Resource for Advancing Cancer Education, nor those of Swedish Cancer Institute. The contents of this program do not constitute medical advice, and they are intended to supplement but not replace input from an individual patient's medical team. As we begin the discussion of never smokers with lung cancer, we need to clarify the generally accepted definitions of smoking status within this field. Never smokers are those who have smoked fewer than 100 cigarettes in their lifetime. Ex-smokers are those who quit at least a year before diagnosis, and current smokers are those who continue to smoke or quit within less than a year of diagnosis. About half of new lung cancer patients are ex-smokers, while never smokers comprise about 10 to 15% of most lung cancer series in North America. Though obviously a minority of the general lung cancer population, never smokers with lung cancer account for about 20,000 or more new cases in the U.S. each year, which would rank it in the top 10 most common cancers even on its own. In fact, studies from Asia tend to see up to a third of patients as never smokers, higher numbers than seen in North America. Lung cancer among never smokers disproportionately affects women compared with men all around the world. It is also most commonly an adenocarcinoma and quite often the bronchioloalveolar carcinoma or BAC subtype. In trying to discern the underlying causes of lung cancer in never smokers, secondhand smoke exposure, radon, possible occupational toxins, and pollution have all been implicated, but this remains a largely unexplained question. Though there is still a great deal to learn about the biology of lung cancers in never smokers versus those in smokers, the available genetic evidence clearly and consistently indicates that the lung cancers developing in never smokers are genetically relatively simple compared with those developing in smokers, and they appear to be very different from the surrounding normal lung tissue. In contrast, the lung cancer tumors of smokers has a larger number of mutations and is genetically similar to the surrounding lung tissue, which tends to have genetic features different from the non-cancer lung tissue of never smokers. Overall, this work suggests that the lung cancers of never smokers may be more of a random key hit compared with those arising in smokers, which appear to be more of a cumulative effect of many genetic abnormalities seen throughout their lung tissue. Some studies have demonstrated that never smokers have a superior survival compared with current or ex-smokers. One large review is of the experience of lung cancer patients over a 4-year period from Henry Ford Hospital in Detroit, where only 8% of patients were never smokers. This review demonstrated that survival was significantly worse in current or ex-smokers, though smoking was also associated with a greater frequency of other medical problems, worse nutrition, and overall less treatment. Nevertheless, when these factors were isolated in a separate analysis for these related variables, there was still a significantly better survival seen among never smokers. Similar conclusions have been seen at the Moffitt Cancer Center in Tampa, where they looked at 654 patients with adenocarcinomas. Within this population, never smokers were disproportionately women, more likely to have the BAC subtype of lung cancer, and had a significantly better long-term survival, even when the investigators took into account related variables and isolated the difference of smoking status. We've also seen better survival among never smokers specifically in the setting of advanced non-small cell lung cancer. In the trial comparing cisplatin gemcitabine, also known as Gemzar, to cisplatin and pemetrexed, also known as Alimta, both treatment groups demonstrated a 5 to 6 month longer median overall survival in never smokers, who comprised about 15% of the patients enrolled in this international trial. But in truth, much of the reason we have focused on never smokers in the last few years stems from the observation that never smokers were particularly more likely to respond to the oral inhibitors of the epidermal growth factor receptor, or EGFR. For instance, in the retrospective review of 139 patients treated with Gefitinib, also known as Iressa, at Memorial Sloan Kettering Cancer Center in New York over a 5-year period, never smoking status was among the strongest discriminators of likelihood of significant response. It was also one of only 2 variables that emerged as significantly predictive in a careful multivariate analysis that separated associations with overlapping variables. The importance of smoking status and particular benefit in never smokers has also held up in larger studies. The BR21 trial that tested the EGFR inhibitor Erlotinib, also known as Tarceva, versus placebo in previously treated patients with advanced non-small cell lung cancer showed a significant improvement in median overall survival by a couple of months, as shown in the bottom of this figure. When results were evaluated by patient subgroups, never smokers got more benefit than any other subgroup, more than doubling survival with Tarceva compared with placebo, as shown in the very striking separation of the curves on the left, a far greater effect than was seen in the current or former smokers, represented in the curves on the right. The same picture emerges for a very similar, larger trial done with Iressa. Unlike the BR21 trial with Tarceva, the ISOL trial, for the Iressa study in the evaluation of lung cancer, did not show a significant difference in survival for the general trial population, but there was a nearly 3-month improvement in median overall survival with Iressa among the never smokers on the trial, as shown in the separating curves in the bottom left. In contrast, there was no evidence of improvement among the current or former smokers on the trial, as shown in the bottom right. In a trial that I led of Iressa in patients with advanced bronchioloalveolar carcinoma, or BAC, never smokers had a significantly longer survival that nearly doubled that seen in the smokers on the study. In a similar trial of Tarceva in advanced BAC, there was a more than doubling of response rate for never smokers compared with current or ex-smokers. Another trial approach in which never smokers have appeared to receive particular benefit with EGFR inhibitors has been the combination of oral EGFR inhibitor therapy with standard chemotherapy. 4 different trials that compared first-line doublet chemo with concurrent EGFR inhibitor therapy to chemo with a placebo were quite clearly negative for a survival benefit from adding Tarceva or Iressa, including this one, called Tribute, that added Tarceva or placebo to up to 6 cycles of carboplatin and paclitaxel, also known as Taxol. Nevertheless, this negative trial was positive for one specific subset of patients, and that was never smokers, in whom there was a significant improvement in both overall survival on top and progression-free survival on the bottom. This result is a leading reason why some oncologists recommend concurrent chemo and Tarceva for some patients, particularly never smokers, though I would highlight that the curves really separate only about 6 months into the trial, when the 6 cycles of chemo are completed. I believe that the never smokers did well with this approach despite, and not because of, the concurrent chemotherapy. We can hope to get some information about this question from a still ongoing trial for never smokers or light former smokers who are being randomized to chemo with Tarceva or Tarceva alone. To summarize, never smokers account for over 20,000 new cases of lung cancer in the U.S. each year and have several features that are distinctive compared with the lung cancer arising in current or former smokers. Never smokers with lung cancer are particularly common in Asian populations and disproportionately affect women for reasons we don't yet understand. The lung cancer in never smokers tends to be an adenocarcinoma and often the BAC subtype, with up to a third of patients with BAC as never smokers. The tumors in never smokers are overall less genetically complex. Perhaps related to this, they tend to be more responsive to our treatments, as survival is consistently longer in never smokers. This is seen in a range of trials, but it has been most pronounced in studies of oral EGFR inhibitors. In the positive trials, never smokers are the subset with the greatest benefit, while in the overall negative trials, never smokers emerge as a subset in whom a benefit can still be seen. These trials are with Tarceva or Iressa, alone or in combination with chemotherapy. There is still a great deal we need to learn about why lung cancer emerges in never smokers and whether there are particularly effective approaches to pursue in these patients, but this topic has exploded as a field of research within the last few years. Never smokers are being more carefully studied as defined subsets in larger trials, as well as in specific trials dedicated to never smokers with lung cancer. Among the most important questions to address is whether the clinical variable of smoking status is really the relevant variable, or that being a never smoker is correlated with one or more molecular variables that are really the key here. We'll cover this question as a separate presentation. You can find additional information on several of these topics within the subject archives at the web address www.cancergrace.org/lung. Members of GRACE can also leave comments and questions about this presentation at the web address below. Thank you for your interest.